Good evening, friends. Just setting up the thing and expecting the faculty to join shortly. And with respect to the due time, we start ahead with the class. I request all of you to keep themselves in mute mode. Those who are presenting and faculty, please unmute yourself. Today we are having two important exam cases. One is a case of a mass abdomen. The other one is a case of a gastric outlet obstruction. Both in the upper abdominal pathology, but a different presentation. I'm sure this will be a useful session for students as well as a teaching session for the faculty as well. So I warmly welcome all our advisors of the PG clinics. We have Dr. Raji Sahai sir. We have others to join in. And we have Hemant Natyal sir, who has been kind enough to contribute the student. And the other student is kindly contributed by Dr. Gayatri ma'am. Vineet and Vaibhavi are basically from Himalayan Institute of Medical Sciences and Government Stanley Medical College. So we'll have Vineet to present his case first. I'm sure all the faculty have been with us earlier. So the candidate is allowed to present non-stop till the end of the history part, and the candidate can sum up the history. And subsequently, the examiners can revisit from the first slide onwards and to ask questions. So that is a plan. And then the second half is for the clinical examination part. And we also will be covering up with the management part. Each case we allow 1 hour. I also request the faculty to kindly give the answers if the student find difficult to answer or not able to give the answer to your expectation. So this will be a teaching mode so that we can give the student to pursue further so that the discussion keeps going. Madam, welcome, ma'am. Aparna, ma'am, welcome. Rajgopal, sir, welcome, ma'am. Gayatri, ma'am, welcome. So, I think we are having the Dr. Ajay Khanna, sir. Good evening, sir. Welcome, sir. So, let us have the presentation first. Dr. Vineet, can you introduce yourself, your unit chief, your head of the department, and start your presentation? Good luck to you.
Thank you, sir. This is Dr. Vineet. Good evening, all the faculty and all the PGs who have joined the session. And I'm Dr. Nalluri Vineet, third year postgraduate from Government Stanley Medical College. I belong to Professor S.P. Gayatri ma'am, head of the department unit, Stanley Medical College.
Yeah, good evening, Vineet. You can start your presentation.
Okay, ma'am. Thank you, ma'am.
Share your PowerPoint, ma'am.
Yes, sir. Yes, sir. Sharing, sir.
Yeah, good luck to you. All the best.
Yes. So, Mr. X, who is a 40 years male.
Dr. Vineet, one moment. With the permission of everyone, I'm going to mute everyone because it looks we have some disturbance and some people are accidentally kept the mode on. So I request all of you to unmute and continue to speak. Please go ahead.
Mr. X, who is 40 years male, hailing from Chennai, occupation by farmer, came with the chief complaint of pain abdomen for 2 months and the complaints of black tarry stools for 2 weeks. History of present illness, the patient was apparently normal 2 months back. Then he developed abdominal pain in the epigastric region, dull aching in nature, insidious in onset, gradually increased in severity for past 2 weeks. Pain aggravated on taking food and reduced by induced vomiting. And there is no radiation of pain. History of dyspepsia was there, history of vomiting, which is induced, history of black tarry stools for 2 weeks, history of loss of appetite and loss of weight. There is no history of hematemesis, no history of constipation, no history of fever, no history of cough or shortness of breath. In the past history, a patient is not a known case of any acid peptic disease, no previous history of abdominal surgeries, not a known case of diabetes, hypertension, tuberculosis, C. area, CK. In personal history, patient consumes mixed diet, alcoholic and smoker, normal sleep and decreased appetite, normal bladder habits and passes black tarry stools. Family history, no family members have gastrointestinal malignancy. In the summary, 40 years old male with complaints of pain abdomen for 2 months and passing of black tarry stools for 2 weeks with loss of appetite and loss of weight. I conclude the pathology tract. Can I proceed further now?
I couldn't hear the last sentence. There was some break in the signal.
Yes, ma'am. The summary is like 40 years male with complaints of pain abdomen for 2 months and passing of black tarry stools for 2 weeks with loss of appetite and loss of weight. From the above history, I conclude that patient has pathology in gastrointestinal tract.
Yeah, I
Okay.
mean, this is look, Dr. Vineet,
Yes.
you can't say patient is, I mean, can you even broaden? Patient has some trouble. Gastrointestinal tract, what do you mean by gastrointestinal tract? What could be a differential here?
Sir, it might be a chronic gastric ulcer or a gastric malignancy, sir.
Okay, so you think it's a peptic ulcer syndrome?
Yes, sir.
What do you mean by chronic gastric ulcer? What do you mean by this? Is there a term called chronic gastric ulcer? Is there a clinical term for it? Chronic gastric ulcer?
Sir, the patient here will have a pain immediately after intake of food and repeated usage of proton pump inhibitors, and patient will have symptoms like hematemesis, melena and hematemesis.
No, I mean,
All
what is
patients
chronic
will have
gastric ulcer?
hematemesis. Huh.
What is chronic gastric ulcer? I mean, is that a clinical diagnosis? Chronic gastric ulcer.
It is a peptic ulcer disease, sir.
Yeah, you come straight away with peptic ulcer.
Yes, sir.
Yeah, ma'am,
Peptic
please.
ulcer. Yes, sir.
Vineet, can you elaborate on vomiting here? You just said the patient had the vomiting. That is one of the very important symptom here.
Yes, sir.
You did not tell anything about the one, just said the vomiting is there.
Yes, sir. So, in a patient here is taking the food after intake of food. Patient is feeling like bloated sensation, and patient there is increase in pain after intake of food. Then patient has induced vomiting by himself, by purging. Then the pain has been subsided here, sir. That is
And
why,
how much,
like as
how,
such, patient does not have vomiting continuously, but patient has induced vomiting here.
and how much does it vomit?
Sir, patient like half of the contents what he had ate, he has vomited out, sir.
Is it a bilious vomiting or
Yeah.
non-bilious vomiting?
Non-bilious type of vomiting, sir.
Okay, all these things has to come because your diagnosis will change according to that.
Yes, sir.
Dr. Vineet,
Yes,
is
ma'am.
it related, pain is relieved by vomiting? That is also very important, no?
Yes, ma'am. Pain is relieved on vomiting, ma'am.
Why is he induced vomiting? For what?
Ma'am, patient is complaining like after immediately intake of food, there is increase in vomiting. That might be due to the distension of the stomach, or patient might have ulcer over there in the gastric. Usually in gastric ulcer, pain is increased by intake of food, ma'am.
So, Dr. Vineet,
Gastric ulcer?
every symptom.
Yeah, continue, madam. Within
Yeah.
half an hour, if they are vomiting, that may be related to gastric. It is not that anybody who has got GOO can vomit.
Yes, ma'am.
But why is inducing? What happens? Why the patient is inducing? For relief of pain or bloating sensation, and what type of vomiting it is, whether it is relieving, everything you should describe, no? That is very important. And loss of weight, loss of appetite. Did you tell how much is the loss of weight? Is it significant or not significant? That is also important.
Ma'am, yes, ma'am, it is significant loss of weight. As the patient attendants have observed that thing, and they have told that patient has lost almost 10 kgs of weight in the past 2 months, ma'am.
So basically, Dr.
Doctor,
Vineet, you understand that every symptom that you have told us, you have to elaborate.
Okay.
So you were asked about 8 questions regarding vomiting. So this information should be forthcoming when you detail your history.
Okay.
Because if you leave it to the examiners, then you will not proceed towards anything more. And at the level of MS, you have to give a lot of information beforehand. so that the questions are then more directed towards something that will fetch you marks, right?
Okay.
So if we are asking you what type of vomiting, was it projectile, non-projectile, was it bilious, non-bilious, what was the content, what was the volume, all these things should be there in the history.
Okay.
Similarly, for pain, you have just said pain in the epigastrium radiating to the back. What is the intensity? Does he get up in the
No.
night because of pain? So there are so many
Aggravating and relieving factors of pain, both you have to
aggravating
tell, no?
also. All
Yes,
the
Relieving factors of
SITAR.
pain.
yes, ma'am. Pain is aggravated on intake of food and it got relieved either by taking medications or by immediately vomiting, ma'am. Like he is inducing the vomiting, he is self-inducing the vomiting. Vomiting is not there per se, but patient is inducing the vomiting, which is non-bilious and it contains partially digested food.
Black tarry stools you are telling. How to differentiate between melena and is it just dark colored stools? Did you ask questions regarding that or everything you should substantiate whether it is melena or something else, no?
Yes, ma'am.
What questions asked?
Patient has observed that black color stools are there while he's defecating, ma'am. I asked whether any change in other color, whether usual or regular stools he is passing or whether any specific change.
No, you have to ask him whether he is taking any tablet because he is anemic or he may be taking any medications. Should ask for any medications he is taking which causes black colored stools or whether it's sticky. How is it? So that how to differentiate melena and just dark colored stools. That is very important, no?
Yes,
Whether it
ma'am.
is melena or anything else.
Patient as such does not have any past treatment history, ma'am. For the past 2 months, only due to the pain abdomen, patient has been taking some NSAIDs from private hospital, and patient does not on probing the patient, he didn't reveal he does not have any history of taking iron tablets, like for anemia.
So
Patient,
what is the characteristic of melena? Black tarry stool is one of the characteristics. What are the other characteristics to say that it is melena? No, there are specific words that are used to describe melena, and not just black colored stools because of drugs or because of any other reason.
sorry, ma'am, I couldn't be able to answer this question.
Oh, would you like to proceed with
Are
this?
they foul
So
smelling or not?
No, sir, not non-foul smelling stool.
So if it is non-foul smelling, then it may not be the melena, then, isn't?
Yes, sir.
Because melena stools are very foul smelling
Foul smelling.
and they stick to the pan. That's
And
very characteristic of that. Okay, apart from the black color, they stick to the pan.
Dr. Vineet, it's a 40-year-old gentleman with a history of 2 months.
Yes, sir.
So do you think it can be gastric ulcer without a history of chronic NSAID or anything?
No, sir. Previous history, patient, no, sir. It is highly unlikely. But the gastric,
No, I mean, okay. So you said one is that it could be gastric ulcer,
yes, sir.
right? Or peptic ulcer syndrome.
Yes, sir.
Why can't it be a duodenal ulcer?
Sir, here, patient specifically complains of pain immediately after taking food. In duodenal ulcer, food relieves pain, sir.
And what would weight?
Patient has loss of weight, in a duodenal ulcer, patient will have, it is called as hunger pain. Patient will gain weight. In gastric ulcer, patient will have loss of weight, sir.
Okay. So what do you think now? There's just 2 months history with
Yes,
black tarry stools with he induces vomiting, right?
yes, sir.
Do you think in gastric ulcer a person would induce vomiting?
No, sir. Person will not induce vomiting in gastric ulcer, sir, but like
So
Patient,
in which conditions do patients induce vomiting? Why does that happen? Why does he have to induce vomiting?
as such, in this case, in order to relieve pain, only patient is inducing vomiting,
Only
sir.
for pain, or is it for bloating, or he's got that sensation of fullness?
A patient has complaints of fullness also, sir. Complaints of fullness and along with
So when there is
pain.
gastric dilatation, when there's a lot of stuff in the stomach which has not been emptied,
Yes, sir.
right? He will
Yes.
always have the sensation of fullness.
Yes.
He'd like to empty it out,
Yes, sir.
right?
Yes, sir.
Okay. So now, what do you think?
Yeah,
Could
Vineet,
be
Vineet,
Sir.
yeah, so that fullness is a very important point. You cannot ignore that, while presentation, fullness, because uh, gastric ulcer patients having it in lesser curvature and little higher also can induce, but they may not complain of fullness. What is early satiety? Did you mention that?
No, sir. Early satiety I didn't mention. No.
Did you mention that?
No, sir. I didn't mention in my history, sir.
Did you mention that how much is able to eat some small quantity? What used to eat earlier? Epigastric, sir, mentioned about bloating, distension. So do you consider carcinoma stomach at this stage?
Sir,
Gastric ulcer is, yes, you have mentioned, but look at the last two words which you have written there, loss of appetite and loss of weight.
yes,
So do you consider? Yes or no? That's
sir,
all.
within loss of appetite and loss of weight are the same which will be seen usually in malignancy, sir. So I suspect gastric malignancy to be there.
So if that's what your answer should be, you cannot rule out. It has to be considered. Now, the
Yes.
next question to follow is why these patients have got pain abdomen? How do you explain that? You mentioned that pain radiating to the back, correct?
No, sir. Pain is not radiating, sir.
Not radiating to the back. So, what
Yes,
is the cause of this?
Sir, pain here is due to distension of the stomach, sir.
So, that is why it's important to carefully ask this question. Some
Yes.
epigastric discomfort interpretation as a pain, because pain is not a feature of carcinoma of the stomach.
Carcinoma. Yes, sir.
Unless suppose if there is a antral obstruction, pyloric antrum, what do they complain to you? Antrum.
Pyloric antrum obstruction, patient will have symptoms of gastric outlet obstruction.
And you already mentioned, no, all that bile, this, that, and all that undigested. What I wanted is a ball rolling sensation,
Yes.
So, in other words, that also some people may complain as, pain abdomen. Usually, it is not a common complaint unless it is an advanced stage, right? With
Yes.
the posteriorly infiltration, etc. Okay. So, do you know that pre-pyloric lesions, gastric ulcer, can they turn into malignancy? Do they behave like that, or you heard of that? You know the classification of gastric. Okay, I think we can ask later. Okay, sir.
okay, Vineet, just one more point.
Yes, sir.
How can you distinguish by the vomiters whether this is a patient of gastric carcinoma or a gastric ulcer? Can you, by vomiters?
Usually in gastric malignancies, malignancy will bleed, sir. So food will be admixed with the blood. So hematemesis might
Not
be.
necessary, not necessary, not necessary. There's a very peculiar characteristic of gastric malignancy, that is achlorhydria.
Yes, sir.
Right?
Yes, sir.
While in peptic ulcer disease, the acid level will be always high.
Always high.
So when you have to ask, when he vomits, does the vomiter stain the floor or not? Because if there's acid, the floor will be stained. If there's no acid, the floor will not be stained. Do you get me?
Yes, sir.
So that's a very important factor to distinguish between gastric carcinoma and gastric ulcers. Can we go to your first slide? We've not discussed your history at all. So what's the mean age for gastric carcinoma?
So more than 50 years of age, sir.
Right. Okay, next. What are the risk factors for gastric carcinoma?
Risk factors for gastric carcinoma are obesity, smoking, alcohol, then predisposing lesions like pernicious anemia, atrophic gastritis, Helicobacter pylori infection.
No. Okay. We are not. In your history, have you taken out the risk factors for, have you elicited the risk factors for gastric cancer or not?
Yes, sir. Yes, sir.
Let's continue. No.
You can go
just go
ahead
back.
to physical examination.
Okay.
Okay.
Oh,
We'll
no.
discuss.
No, was there a question? Sorry, I thought.
No, I just wanted to discuss his history, whether
Yeah.
he has elicited the risk factors for gastric carcinoma or not.
Yes,
Yeah.
sir. Patient is alcoholic and smoker, sir.
That is one. What about diet? What is so peculiar about the diet in gastric carcinoma?
Sir, consumption of red meat products increases, smoked meat products.
Or pickled? India, we don't eat so much of smoked, but we eat pickled,
Pickled.
right?
Yes.
Why pickled? Why pickled and salted pickled? What is so peculiar about it that is?
Sir, high salt intake is a risk factor for
Why?
gastric.
Why? No, it's just not salt. It's not salt. It is pickled by salt. What is that ingredient which induces malignancy?
Nitrosamines.
Okay, nitrates.
Yes,
They do, right?
yes, sir.
Okay.
In India, where is the commonest reason for the carcinoma stomach? In India.
Commonest reason, sir.
Hmm?
So sorry, I am unable to get you, sir.
Which state
Where
has
is
got the maximum cancer? Carcinoma stomach. In India.
Punjab belt, sir.
No. It's the Mizoram.
Okay.
Okay. And then the Tamil Nadu. So these are two states which has got the maximum incidence of in India.
Okay, sir.
And as per the location in the stomach, which is the commonest area?
Antropyloric growths are common.
Okay, after that?
Like proximal gastric region, like fundus and
Yeah,
body.
cardiopharyngeal junction, body of the stomach,
Yes, sir.
fundus, and then whole of the stomach.
Yes, sir.
If this fundic carcinoma is there, which predominant condition you will look for? If the patient has a carcinoma, the fundus is there, which pre-malignant condition you will look for? Look for the pernicious anemia.
Okay.
Pernicious anemia, they have got the maximum chance of having the cancer in the fundus.
Okay.
Which blood group is more common for the carcinoma stomach?
Blood group A, sir.
Blood group A, yes. You know which gene is there? If that is positive, you may have to go for prophylactic gastrectomy for the gastric carcinoma. You know any gene like in the breast cancer? This gene is there. If that is positive, or the thyroid cancer is there, a gene is positive, you may go for a prophylactic operation. Similarly, in the carcinoma stomach, do you know which gene is there where you may have to think of the prophylactic gastrectomy?
I'm not sure, sir. Is it APC gene, sir? APC gene mutation.
no?
E cadherin jo hai na? E cadherin jo hai is the gene. If that is positive, then you may have to think about going for the prophylactic gastrectomy jo hai.
Okay, sir.
Okay. Go ahead, yeah.
Go to the examination, please.
In general examination, patient is conscious and cooperative, thin built, ill nourished, and hydration is poor. Vitals, pulse rate is 80 per minute, regular and normal in volume. BP is 110/70 millimeters of mercury. Respiratory rate is 14 per minute. Febrile, patient is icteric, no sense of cyanosis, clubbing, pedal edema, generalized lymphadenopathy. On examination of the abdomen, consent
1
of
minute. In
Yes.
the general examination, what is the important thing you have left there?
Yes, very important.
Very important.
Very
It
important.
cannot be missed, no?
The patient is vomiting, isn't it?
Yes, sir.
Waiting.
So what do you look for?
Hydration, poor, you have told.
Yes, ma'am.
What else will be there? Icterus is severe, or you look for anemia in this patient? Is it important or not?
Ma'am, look for anemia is very important for this patient, ma'am. Because the patient is icteric, we cannot be able to find out, differentiate the pallor in the patient.
That's why you have not mentioned, huh?
Yes, ma'am.
Where and all icterus is present in this patient?
Only in sclera, ma'am. Icterus is present only in sclera.
Sclera. Then where else you can look for anemia? Other symptoms of anemia, where and all you can look for? See, anemia is one of the important things you cannot miss in any patient with malignancy, that too in this patient.
Yes, ma'am.
So even if you cannot assess pallor, you have to mention that you cannot assess pallor, because otherwise, like just now, how all of us felt that you have failed to assess for pallor. And how is it that in history there is no history regarding the icterus? The patient hasn't been forthcoming with any detail, or you did mention?
Patient does not have any complaint regarding the yellowish discoloration, ma'am. After admitting the patient only, we have recognized that yellowish discoloration is there, and it's our finding. My patient does not have any.
No, what about his urine? Was his urine dark color?
No, sir. Patient does not have any complaints of urine
No,
dark.
did you ask him? Did you ask him once you found icterus? Did you go back and ask him?
Yes, sir. Yes, sir.
Yes.
Because this icterus, it could be just anemia can masquerade as icterus. Severe anemia can. Also, if your patient is he hydrated? Because his pulse seems to be normal.
Yes,
BP
sir.
seems to be
This
tachycardia.
these vitals have been taken after infusing, hydrating him with IV fluids, sir.
Oh, you say so. Say so then. Say so.
Yes, sir.
Right. That you examine the patient in the ward after admission.
Yes,
Right. Because this way we will think that there's something wrong in your examination.
no, sir. The vitals have been checked after hydrating the patient, sir.
So he was dehydrated then.
Yes, sir. Before he was dehydrated, after admission, we have hydrated the patient, and vitals were checked after giving the IV fluids, sir.
So you say that when you examine the patient, he was on an IV line. Right?
Okay.
Do you tell us that? Because otherwise we don't know. Right.
Yes. Consent obtained. Examined in a well-lit room in supine position. On inspection, abdomen contour was flat. Umbilicus is in midline, inverted. All quadrants are equally moving with respiration. No visible mass. And this is the inspectory finding. This is the mass of the patient. And no visible gastric peristalsis, no visible scar or dilated veins or periumbilical nodules. Hernial orifices are free. No renal angle fullness. External genitalia appears normal. On palpation, no rise in temperature, non-tender. Mass is palpable in epigastric region, 7 × 6 cm, irregular shape, irregular surface, firm in consistency and ill-defined borders, extending into right hypochondrium and umbilical region. Inferior border was palpable 2 cm above the umbilicus, and upper border was palpable 4 cm below xerosternum. Insunation on right costal margin was possible. Moving with respiration, no hepatomegaly, left supraclavicular fossa was free, left axilla no node palpable. On percussion, dull note over the mass, no evidence of fluid. Auscultation, normal vowel sounds, no succussion splash. Digital rectal examination, perianal skin was normal, tone was normal, mucosa was normal fecal staining, and no Blomer shelf. Other system examination, cardiovascular, heart sounds are present, no murmurs. Respiratory system, no normal bronchovesicular sounds, no added sounds. On summary, a 40-year male without any.
Why, Dr. Vinit, why are you rushing through the findings? We are not able to assimilate the
Okay.
findings about
Yeah,
the
you go
lung.
to the
Go
initial,
back.
like inspection, you can go back.
Okay.
So there is no visible mass on your inspection.
Yes, ma'am.
Inspection.
And on
Yes.
palpation, you felt a mass which you have drawn on the patient's body.
Yes, ma'am.
Did you take consent about that?
Yes, ma'am. I have taken the consent, ma'am.
Okay. Go ahead.
All the coordinates, they move equally.
All
with the
coordinates.
respiration.
Respiration. We doesn't do that no nowadays.
So what do you say? How do you modify this sentence?
Concurrent.
Proportionately,
Proportionately moving with respiration. Yeah.
right? Because all the coordinates, they do not move equally with respiration. You know?
Yes.
Right.
Should you tell about the hernial orifices in this itself in examination as a routine? I think you have to tell about that also. You missed, no visible mass. Next, go to the next slide.
Yes.
No, why should you tell about gastric no visible
Exactly.
peristalsis? That is enough. No, you cannot say gastric or you just tell whether it is no visible peristalsis. Okay.
Okay. Okay.
So here, why would you even, I mean, are you expecting gastric peristalsis to be seen in this patient and you are mentioning? Or you are just completing the examination, all the components of examination?
Ma'am, patient does not have any symptoms of gastric outlet obstruction. I am suspecting a gastric malignancy. So, in order to elicit all the things I have mentioned about no visible gastric
So
peristalsis.
why do you want to speak about something that you're not expecting and trying to create confusion in the mind of the person who's examining? So if the examiner is not fully listening to you and listening to you in parts, which can happen if you are the fifth or sixth candidate of the day. Okay. So no visible gastric peristalsis, immediately the antennae of examiners go up to think, are you thinking in terms of gastric outlet obstruction? Do you think the kind of vomiting that you described was like a classical gastric outlet obstruction? So then we start wondering whether there is confusion in your mind about what is classical GOO of, ulcer disease. So if you're not expecting something, and if you just want to complete the examination findings, you say no visible peristalsis. That is what I think madam has already told you. And don't create a situation where more and more unnecessary questions may come up for you.
Yeah. Next slide.
Why periumbilical nodule? Specifically, you mentioned periumbilical nodule.
Sir, in gastric malignancy, metastasis to umbilical region, like Sister Mary Joseph nodule. For that reason, I have mentioned about periumbilical nodules.
That occurs in the periumbilical area or in the umbilicus?
Umbilicus, sir.
So why you mentioned periumbilical? That's what I'm asking. It has to be, if you are going to mention Sister Mary Joseph, it has to be the umbilical nodule.
Yes, sir.
It occurs right in the umbilicus.
Yes, sir.
Why does it occur? Why does it occur right in the umbilicus?
Sir, it is a lymphatic, it is a metastasis, sir, skin metastasis from lesser curvature to ligament of teres. Then it will go and deposit in umbilical region, sir.
Falciform ligament.
Yes, sir. Falciform.
Falciform ligament is right at the umbilicus is there.
Yes,
Okay.
sir.
So that is why it occurs right at the umbilicus. Okay.
Yes, sir.
So do not write periumbilical nodule. If you have to write the umbilical nodule.
Okay, sir.
Okay.
Next slide.
See the renal angus when the patient you were inspecting that at this time? When you were examining this patient, you were inspecting the patient in the supine position. How did you see the renal angus on inspection at this time? Did you make the patient sit and again lie down?
No, sir.
So it should not come here.
Yes, sir.
Okay. Yeah. Yeah, go ahead. Yeah.
Then on palpation, there is no rise in temperature, non-tender. Mass is palpable in the epigastric region, 7 × 6 cm, irregular in shape, irregular surface. firm in consistency and ill-defined borders extending into right hypochondrium and umbilical region. Inferior border was palpable 2 cm above the umbilicus and upper border was palpable 4 cm below the sternum. Insinuation on the right costal margin is possible.
Insinuation. Please check that English. Okay, small correction.
Mistake. Yeah.
But it's better that you correct yourself. Okay, see that what I have written. Okay, please. Yeah, thank you.
When mass is moving with respiration, no hepatomegaly, left supraclavicular fossa was free and left axilla no. Yes.
Can you, sorry to interrupt. Can you go back to the photograph where you have demarcated the lump? Okay. So you think this is the epigastric region? Have you checked the proper quadrant?
Yes, ma'am.
Okay. So it is partially in the epigastrium?
To the right hypochondrium.
And then right hypochondrium and also in the periumbilical.
Periumbilical.
Okay. All right.
No notes
you're
in the
saying-
axilla, right? It's a notes or anything else you wanted to mention?
Ma'am, in gastric malignancy, left axillary nodes will be the metastasis usually go to left axillary node, which is called as Irish node. For that reason, I have
Is
mentioned
nodes
about
or
left axillary
nodule? It is a node or a nodule?
left axillary node. Ma'am.
Node.
Yes, ma'am. Node. Ma'am.
It's nodules, ma. It is not nodes. Left axillary nodes. You mean to say the levels of nodes in the axilla will be involved in this?
No.
Go to the slide. No node palpable in the axilla. You palpated inside the axilla, is it?
Yes, ma'am.
Hmm?
So
And what about the...
Have you finished your abdominal examination? You have gone to supraclavicular and the axilla now. Still, you have not finished your abdominal examination.
Go to the previous slide again.
No hepatomegaly. Did you percuss the abdomen or not?
Yes, sir.
Where is the percussion? Show the percussion. So why it is coming after that? After your supraclavicular and left axilla? Okay, first you have to finish the abdominal examination. Okay.
Okay.
And then you have to go to these areas.
Okay, sir.
Right.
So just one more point to clarify, the lump is, you're saying it is indistinct. There are no distinct margins, right?
Yes, ma'am.
And it's not moving with respiration.
It's moving with respiration.
It is moving with respiration, but not clearly defined in all the margins. Yes, okay. Any additional test you have conducted on this, on the lump, to understand whether it is an intraperitoneal lump or a retroperitoneal mass?
Ma'am, a leg grazing test I have done, ma'am. In that lump has prominence, prominency of the lump has been decreased. So I confirmed it as an intraabdominal mass.
Which test did you do?
Leg grazing test, ma'am.
Leg grazing to find out that it is intraperitoneal. And how will you differentiate whether it is retroperitoneal or intraperitoneal?
During leg grazing test, the lump prominence of the lump will decrease if it is arising from intraperitoneally.
Yeah, and also if it is retroperitoneal, it will also decrease only, no?
Yes, ma'am.
Leg grazing will not tell you whether it is retroperitoneal or intraperitoneal. It will only tell you intraperitoneal or extraperitoneal.
Extraperitoneal.
Anterior, not posterior.
Okay.
Yeah. So which test can you do? Why am I asking this question? Because all your history, you are focusing only on one diagnosis or one organ, and that is the stomach.
Okay.
Could there be any other organ there which can give rise to pain, which can have melena through some alternative route?
Pancreas.
So can you, for that, you need to clinically now find out what type of, where the lump is located. And can you do that with any clinical examination?
in your patient, will you do a leg raising test or will you do a head raise test in your patient?
Leg raising test.
Where is the lump?
Where is the lump?
Epigastric region.
Is it in the upper abdomen or lower abdomen?
Upper abdomen.
So
So
for the
what
upper
will you do?
abdomen, what you do?
A head raising test.
Yeah, you should mention head raise test, not the leg raising test. Okay.
Okay. Yes.
Yeah.
Vineet, could you go to your palpation of your lump, please? Okay. So, what do you think is this lump arising from which organ? It's in the epigastric region.
Yes, sir.
Irregular shape, irregular surface, and firm in consistency, ill-defined margins. Okay. So, what do you think is uh, could be the organ of origin of this lump? What are the structures there which can give rise to this kind of lump?
There is the epigastrium from stomach lump can be presented. Then from pancreas also. From pancreas.
Have you told the mobility of this lump?
Yes, sir. Mobility of the lump is there, sir. Then
Have you mentioned anywhere the mobility of this lump?
yes, sir. I have mentioned, sir.
Where?
Where it is? Just show that.
Oh,
Moving with
mobility is
respiration.
not mentioned.
Moving with
Mobility is not mentioned.
So do you think that is
Okay.
not important here? Mobility of the lump?
Yes, sir. Important.
Yeah.
So,
that
was it
And
mobile or not
also,
mobile?
there are two
Was it-
types of mobility also in it. So one is a mobility which is a downward mobility with the diaphragmatic descent.
Distant. Yes, sir.
The second mobility is a rocking mobility because of the spine. So you also have to mention what type of mobility, because that again gives you, all these are your pieces of your jigsaw. If you put them together, you will get a good picture at the end of your clinical history and examination. So what type of mobility have you seen? Is the edge of the, first of all, the edges are not very distinct, but still you are saying that the lump is moving with respiration. So does the lower end move down with the every breath that the patient takes?
Yes, ma'am. Lower and moves with respiration.
Okay. Okay,
So,
go
what
ahead.
would be the characteristic of a lump which arises from the transverse colon, from the stomach, and from the pancreas? Will you be able to distinguish between the three lumps? It can be from the transverse colon or not?
Yes, sir. There is a chance lump arising from transverse colon also, sir.
Right. So, how will you distinguish between the three lumps? What about the stomach? What about the transverse colon?
Sir, if the lump is arising from stomach with obstruction, then visible gastric paresthesis will be seen moving from.
No, don't add with obstruction, without obstruction. I'm just asking you, how is a stomach lump different from a transverse colon lump? You've said it.
Yes,
Will a transverse colon lump move with respiration?
yes, sir. It is an intra-abdominal. It moves with respiration.
All intra-abdominal, intraperitoneal lumps move with respiration, do they?
No, which are connected to diaphragm will move.
Right.
Yeah.
So, right. But so a transverse colon lump may or may not, but it has a side-to-side movement,
Movement. Yes.
right? It will have a side-to-side movement. It will be much more mobile than a gastric lump.
Gastric.
And what about a pancreatic lump?
Pancreatic lump is like more of fixed ones, sir. Like posterior part is fixed.
So, no, I'm asking you about the mobility. You're telling me about fixity.
Sir, it is like it moves from side to side only, sir.
Pancreas will not have the, yeah, ma'am. It will not have any kind of movement. Doesn't have much movement,
Yes.
right? There's not much of space there,
Okay.
right? What about no rise in temperature? You've already said the patient is afebrile. So what are you looking for here? No raise in temperature. It should be rise in temperature.
No, sir.
Where do you test for temperature? And why?
Sir, for palpating the lump,
You think it's an inflammatory lump?
no, sir,
Look,
not really.
look, Vineet, you're going to be a surgeon. Talk like a surgeon, and you never do that. Do we do
Yes.
that?
No, sir.
No, we don't, right? Okay. Next slide, please. No hepatomegaly. Okay. Right. No. Okay. Let's go to your percussion. There's no free fluid. Okay. And now about on succussion splash. What do you mean by succussion splash? How did you do that?
Sir, we'll ask the patient to take around fluid, then immediately holding the abdomen between the hands, and we'll rock the abdomen.
Vineet. If you suppose you take half a bottle of Coca-Cola, right?
Yes, sir.
And then I put a stetho on your tummy and shake you. Will I get a succussion splash?
No, sir.
No.
Will not?
Sir, yes, sir.
Try it. Try it. Try it yourself. You do, yeah.
Yes, sir.
So there's a corollary attached to it, that it has to be, the patient has to, between the taking of the fluid, how fast does the fluid go out from the stomach normally?
Normally within 30 minutes, sir.
Yeah, 10-15 minutes goes away. So you got to give it time, right? So you ask the patient to take fluid, then wait for half an hour, then come back, and then start shaking them. Okay. So that's how you do it. Can you map this? Have you mapped the stomach? How do you map the stomach?
Sir, no, sir. Stomach was not distended, sir. So it couldn't
How
be
do you
able.
know it's not distended? How do you know it's not distended? Clinically.
Clinically, the patient does not have any complaints of outlet obstruction. So he
He's again, you're assuming. How do you know he doesn't have? He has vomiting or he induces vomiting, right?
yes, sir.
He has fullness and bloating and all that. So he has got some sort of. So okay, you've not done it, but tell me, if you had to do it, how would you do it?
So I'll keep the bell of the stethoscope left to the mask, and radially I will strike. Then I'll watch for change in resonance note. Then I'll mark the greater curvature, sir.
So you got to keep your set, and you got to scratch over the thing or flick over it, and you get
No, sir.
because the
Radially.
stomach is full of the stomach is full of water,
Yes, sir.
right, or fluid, right? So it'll have give a different sound rather than in the abdomen. So that's how you mark it, right?
Yes, sir.
So even if you can't make out whether just by other ways, by percussion, whether it's enlarged or not, you'll have
Yes.
to do this. Okay.
Yes.
Yeah.
We
Next
need,
slide.
if you have to do a succussion splash and the visible gastric peristalsis, you have to demonstrate both the tests. Which one you will do first? Will you do a succussion splash first or the visible gastric peristalsis first?
The succussion splash.
Why? Why you will do a succussion splash first?
Sir, like for visible gastric peristalsis, there need to be stasis of the fluid. Then only we can see the visible gastric peristalsis. For succussion splash, uh, fluid should be there with minimal amount of air. Then we can rock the abdomen so that we can feel the splash.
For the succussion splash, the patient has to be nil only at least for 1 to 2 hours. then only you can demonstrate. Otherwise, if you do the succussion splash after taking immediately after the meal, in your case also it will be present. And for demonstration of the visible gastric peristalsis, sometimes you have to give the patient to drink a glass of water to demonstrate that visible gastric peristalsis.
Yes,
So
sir.
that is why you have to always do the succussion splash first and then the visible gastric peristalsis. Okay.
Okay, sir.
Professor Dalvi has raised his hand. So, sir, please.
Sir, we have got only 10 minutes and lot of investigations, everything has to go on. So
Right. Yeah, please. Yeah, please.
So can we discuss some diagnosis, differential diagnosis now?
Yes, please, Dan.
Ma'am, with this, I suspect malignancy from gastric malignancy. And also gastric ulcer.
Will you get a mass in gastric ulcer?
No, sir.
Then why you are thinking of the gastric ulcer now? You have to think, primarily there's a mass is there. So you have to make a differential diagnosis of that particular mass.
Yes, sir.
In which condition does a gastric ulcer present with a mass?
Gastric ulcer with outlet obstruction, anthropoid thickening, it will present as a mass.
No. It will never present as a mass, only if there is a thickened gastric antrum. Only if it is having a slow contained perforation, it may sometimes present as a mass. Usually it grows into the lesser side, so you will not feel it anterior. Okay, so very unlikely that a peptic ulcer disease with a gastric ulcer is going to present with a mass. So any other differential you would like to give apart from gastric malignancy?
Mass and loss of appetite.
Pardon?
Yes, ma'am. All my things points towards a gastric malignancy only, ma'am.
Your patient is jaundice also, isn't it?
Yes, sir.
And
Yeah,
lump is in the right
jaundice
hypochondriac.
also.
Yes,
Yeah.
sir.
So
And
did you think of anything lump which is there and the patient in the jaundice also? Because you are just confined to the stomach. You are not thinking anything in the periphery there.
It might
Can
be
it be a gallbladder mass? It is moving with the respiration. The patient has a carcinoma of the gallbladder with jaundice. So all these things has to be kept in mind in your case.
Yes, sir.
Okay. Yeah.
And again, head pancreas malignancy can also be one of your differentials. The area is exactly in the area of head of pancreas.
Yes, sir.
You have not done the knee elbow position test to find out whether the lump falls forward or it becomes less palpable, which would have told you whether this is an intraperitoneal or a retroperitoneal mass, right?
Yes.
So you have to do all the tests that are there at your disposal in order to be able to bring out more of the factors.
Okay.
And your differentials have to be there. So it's very difficult, very, very unusual to just have one diagnosis at the end of clinical history and examination. Okay. You should generally have arguments for or against.
Okay.
So here, can you argue against a head pancreas lesion?
Head of the pancreas lesion, mobility is it is not mobile, ma'am. Then it is posterior to the stomach, and lump will be not that much prominent here during palpation, and it does not.
That is something very difficult to predict, because if the patient comes to you in a very advanced stage like this person has, it's very difficult to say that lump will not be palpable. And that need not necessarily be adenocarcinoma. There are many other types of malignancies also, which may be larger, presenting as larger lumps. So if you confine yourself to one organ, then it becomes little difficult to defend all the parts. So
Vineet,
how will you proceed with the?
Vineet, just one word, madam. Sorry. Just
Yeah,
try to develop these skills of asking yourself what is in favor of stomach, what is not in favor of stomach. If so, what is favor of the pathology? Carcinoma. Why not 1, 2, 3? Next, why not pancreas? And if so, how will I explain bleeding? Tarry stool. So, periampullary can, but the next question they ask you, why jaundice? Is it obstructive or not obstructive? Is there itching? Have you mentioned anywhere itching, scratch marks, etc.? Gallbladder palpable, not palpable. If it is any other mass, so try to explain possibility. Try to ask that question to yourself and deduct, add. So that's how you say the diagnosis. So please try to develop that reasoning skills. Okay, thank you.
Okay.
What investigations you will do?
From like baseline investigation, I'll go with an ultrasound examination first in this patient. Then I'll proceed it with UJ upper gastro endoscopy. Then I'll go.
You have to tell us what are the findings that you're looking for, and we didn't ask you to go for diagnostic investigation.
Okay.
If that is not the question, then you have to start with basic questions. But let us go to the diagnostic investigations.
Well, in first I'll go with an non-invasive investigation like ultrasound, which is available everywhere. I want to know about the status of the lesion, and I also wanted to know the status of the nodes, and along with the presence or absence of ascites can be known by ultrasound ultrasound examination of the abdomen. Then after this, I'll go for an upper GI endoscopy.
In this particular patient, you also want to look at some other finding. Patient has jaundice,
Yes,
and
ma'am.
status means you want to see the organ of origin.
Yes,
You
ma'am.
cannot evaluate the status of the lesion on ultrasonography. You can maybe make an estimate about the
Yes.
organ of origin.
Organ of origin. Yes, ma'am.
Yeah. Presence of nodes, presence of ascites.
Yes, ma'am.
And in this patient, presence of any intrahepatic biliary radical dilatation,
Dilatation.
any liver lesions.
Yes.
What is the next step? UGI-scopy.
UGI-scopy.
Okay.
Yes, ma'am. In UGI-scopy, I will see the status of the esophagus, and also I will see the status of stomach and the mass from where it is arising. And I'll see the distal limit of the tumor, whether the scopy can be passed crossing the lesion or not.
How do you differentiate between a benign ulcer and a malignant ulcer on upper GI endoscopy?
So like benign ulcers are like broad based. They are with everted edges and with regular surfaces, and malignant ulcers are with irregular surfaces and with necrosis in.
First is the site. Okay, it is the site, size, all those things, the way we examine any ulcer.
Yes, sir.
What is the site of a benign and what is the site of the malignant?
Benign ulcers are more on the lesser curvature side, sir. Malignant ulcers are more on a greater curvature.
Right. Size.
Then size will be in benign ulcers like broad base.
Usually less than 4 centimeters.
Okay.
Malignant are usually more than 4 centimeter. Leaving aside the early gastric cancer which are there.
Yes,
But when we are talking the advanced cancer, then size is this one. Then what about the margins or the edge of the ulcer?
margin
Here in a benign and in the malignant.
margins are irregular margins will be there in malignant ulcers, and there will be regular margins, and flat based thing will be there in benign, sir.
Have you heard about ironing out of the mucosal fold? Have you heard that term?
Yes, sir. Aortic
Ironing out. In which case you get that? In benign or malignant?
is benign, sir.
No, in malignant. Because
Malignant.
the submucosal infiltration which is there, you get in the malignant, not in the benign. In the
Okay.
benign, they are converging there.
Yes, sir.
Okay, the mucosal folds are converging. Which one is more deep? Benign or malignant?
Sir,
Benign
malignant
are more deep.
benign or more deep,
They
malignant are
excavate.
flat.
They
Yes, sir.
excavate there. While the malignant, they are more proliferative type.
Yes, sir.
So all these are differences between a benign and a malignant ulcer. How many biopsies you will take for confirmation of the diagnosis?
Minimum 6 to 8 biopsies to be taken, sir.
So after you have done the upper GI endoscopy, you have taken the biopsy, and the biopsy comes out to be it's a case of a adenocarcinoma.
Yes, sir.
What further you are going to do?
So I look after I look after the other organ involvement and nodal status, sir,
How you look that?
by taking a contrast enhanced CT, sir.
Okay. So how do you read a CT scan usually? Any CT scan which is there, how do you read for a malignancy? It is the
Like
same as the TNM. Okay. You look for the tumor, you
tumor,
look for the nodes, and you look for the metastasis.
metastasis.
Okay. The same thing is done here. You will look for the stomach, you will look for all the nodes there, and you will look for the metastasis.
Metastasis.
Liver metastasis, peritoneal metastasis, or any other metastasis.
Yes, sir.
Okay. It has been done in your patient CT scan.
Yes, sir. CECT has been taken, sir.
Can you show that?
This is the CECT report, sir. It is a semi-circumferential heterogeneously enhancing wall thickening lesion involving the antropyloric region of stomach with maximum thickness of 3 centimeter, causing moderate luminal narrowing on administration of oral contrast, normal passage of contrast beyond the thickening as seen, and malignant growth of stomach with nodal infiltration causing bilobar IHBRD.
Which lymph nodes are enlarged?
Sir,
For the lymph nodes are enlarged?
perigastric lymph nodes, then hilar lymph nodes, pre-aortic lymph nodes are enlarged, sir.
Do you know what are the various numbering given for that, for the various nodes in the
Yes, sir.
stomach?
Like right gastric, it is given as station 1, and
So which station is involved in your patient?
sir, liver hilum is station station 11 and 12, sir.
So can you explain the jaundice in your patient now?
Sir, yes, sir. It is due to the nodal infiltration, which is making the biliary radicals dilated, sir, due to nodal infiltration.
Okay. Any other investigation you have done in your patient?
Sir, UG endoscopy has been done for this patient, sir, and this is the CT thing which is showing.
Just show you have the picture of that endoscopy.
Sir, endoscopy picture we don't have, sir. Actually, that the endoscopy has been done in another specialty department, so we were able to get the picture of the thing, sir.
And the biopsy was done.
Biopsy was done, sir. Yes, sir. Biopsy
Okay.
report is awaited, sir. Biopsy didn't come in, sir.
Is awaited.
Yes, sir. Like,
Okay. What other investigation you are going to do in this patient?
sir, no, I'll do the routine blood investigations for this patient. Like complete blood picture, renal function test and liver function test, to know about the status of hemoglobin in this patient. And also I want to do serum electrolytes. I want to know the electrolyte imbalance and liver function test to know about the protein level in this patient. Then I'll proceed this patient for a nutritional correction state.
You are interested only in protein level?
Liver function test, you have got interest in this patient.
Yes,
Huh?
ma'am. Yes, ma'am.
Only for protein will you do?
No, ma'am. Like total bilirubin and direct bilirubin also I'll see. Then I'll go for albumin levels and I'll correct the patient for his nutritional imbalance. Then I'll prepare the patient for the next appropriate management. Like in this patient, as it is advanced with nodal metastasis, I want to go for a neoadjuvant chemotherapy, and then I want to see
Before you see all these things, your patient must be discussed in the
Tumor board, no?
pardon me, sir.
Where do you discuss regarding this?
No, that word has to come.
Okay.
Yeah.
Your patient has to be discussed in.
Discussed in
multidisciplinary committee. Sir.
Yes, it has to be discussed.
Tumor board, no?
And then only you are going to decide about the treatment of this patient.
Yes, sir.
Okay, I think let us stop here because
yeah, but I just
Dr.
want to
Senegal has
have
given
one
the time
remark.
for that. Yeah.
Yeah, but I'm just going to pass one remark, and looking at the CT scan, Dr. Vinith, I feel that you need to revisit the history of the patient, and you need to really find out the details of that vomiting. I don't think that your history is matching with both the examination findings and the CT scan. So go back and talk to the patient. Okay.
Okay. Thank you.
Dr. Keneval, can we go to the second case now?
I think the permits. Dalvi sir, your hands are going up, sir. Please tell me, sir.
Yeah, it's actually a very straightforward case. I don't know why so much discussion has taken place. For Vinith, examiners will look at details of history, relevance, and when you present irrelevant history, they will catch you. Description of positive findings, mass moving in the respiration does not point to any retroperitoneal organ. If it is intra-abdominal, there is no need for examination of retroperitoneal organs, which you have stated in your history. Present day presentations are the problem because you have got easy availability towards USG, CT scan, etc., which has been covered by Dr. Khanna. So be very vigilant about it. And quick investigations and hence deficit in presentation has been the problem with you. My take home message is right now, this patient has lost a lot of weight. He has lost appetite. You are very clear that this is a CS stomach that you're trying to treat, possibly with metastasis because of his jaundice. Nutrition comes first. The first treatment for me would be to put possibly a NJ tube if at all possible, because gastric cancer treatment comes into a very clear treatment. The first one is cure. Early cancers, gastrectomy, cure. Second is palliation, and that is where we got to decide what is to be palliated. This patient is losing weight. He's got nodes everywhere with jaundice. Two things have to be palliated. Number one is his nutrition, for which maybe surgically gastrojejunostomy may have to be contemplated. Your anterior chemotherapy or radiotherapy, whatever you want to do, is not going to solve his nutritional problems. So NJ tube or a GJ is the solution to the problem, and then start treatment to actually palliate him. That's my take. I'm sure Rajgopal is looking at me with eyes open and may not agree with me, but that's the way I have learned about it. Thank you.
So I think with the permission of the faculty, we'd like to permit the student to ask any question. Do you have any doubts to be clarified to the examiners? Any?
Sir, yes, sir.
Any doubts to be clarified by you?
Yes, sir. Sir, as in the last, sir, Abhay sir has told for nutritional improving, sir, I have one doubt. That patient is already does not have any complaints of outlet obstruction as of now. But he's having a self-induced vomiting. Is that like really necessary to go with an gastrojejunostomy for this patient?
I will answer that question.
Yes, sir.
You have told in your history 2 months of pain and 2 weeks of weight loss. You said significant weight loss. Now I've got one question for you, because you told that his attendant said that he has got significant weight loss. What is the best way of asking the patient if he has got significant weight loss? I'm just extending this discussion. I didn't want to ask you questions because I wanted examiners to ask you questions.
Yes.
But if you ask me whether I've had weight loss, I would say my pants are loose, my shirts are loose. They're simple questions you can ask any patient who will tell
Yes.
you that my weight loss is there. What's your second question?
Sir, that's all, like patient does not have any is that really necessary to do gastrojejunostomy for this patient?
Correct. Now I will answer you that also. You have got a patient on table in OPD who is inducing vomiting. That means stomach is not distended. Now remember, any patient who comes to you knows when to vomit and when not to vomit.
Yes,
You
sir.
have got a diagnosis of CS stomach, which spreads with an ulcer in the submucosa, making the stomach rigid. If you have a patient who says, I have to induce vomiting, there has to be drainage. Now, how do you give this patient drainage? I'm not talking about gastrojejunostomy. I have also said that put in a Ryle's tube into the jejunum across his growth.
Yes, sir.
And start feeding him till you decide on the treatment. A
Okay.
nutritionally bad patient, if you start on chemotherapy, is going to become more bad.
Yes, sir.
You have to realize that. So in patients, this patient's treatment where there are nodes, there is jaundice, there is a growth. For me to start any treatment, there has to be some nutritional value that has to be given to the patient. Okay, so I'm not straight away going for gastrojejunostomy for sure. Every attempt I will make, maybe feeding jejunostomy. Rajgopal, you have anything to say?
I think that I fully agree with you. It's a nasojejunal feeding to be, improve building up. Then try chemotherapy. And where do you do the GJ in this patient? There is no place. Such an extensive mass. As we have rightly pointed out, if it's only antrum, you would have got a visible gastric peristalsis. Earlier, used to call it as localized linitis plastica. This for me looks like a very large one going from antrum to a lesser, greater curve everywhere. There's no place at all. If at all, it's a candidate for, as it's been mentioned, locally resectable if it is there, sometimes with the chemo and all, if it shrinks down, if you have to reassess it, there are many things to be discussed here, including diagnostic laparoscopy, etc. later. But for the time being, you should keep it in mind. There's no role for GJ in this your patient. You will land with somewhere in the high, somewhere near the greater curvature, and you will create misery for this patient. So nasojejunal, chemo, and then reassess. Sir, I think so. That's what I feel.
I completely agree with you. I'll go with feeding jejunostomy or NJ.
Sir, I absolutely agree with both of you, sirs. But I also just want to reassert for the PGs that all these components should be discussed in the examination. So you have been given 1 hour for discussion. So your history and examination findings should be so concise, precise, and without missing anything. Then we can go on to discuss the, investigations, treatments, everything. So whatever you will be having only 20 minutes when you present in MS. So you have to be that much sharper.
So thank you, madams. Thank you, Vinith. I'm sure you would have taken note of the additional areas where you have to keep your knowledge spruced up. Now, with the permission of the faculty, can I call Vaibhavi to share her presentation, introduce herself, her unit chief and head of the department, and start your presentation, Vaibhavi. Good luck to you.
Good evening, respected consultants.
Can I make it full screen, Vaibhavi?
Yes, sir.
I'm not discouraging you like this, but remember, you don't say that case presentation of proximal.
You're good to go, ma. Good luck.
Yeah, okay, please go ahead. Sorry.
Good evening, respected consultants, seniors, and colleagues. Today, my name is Dr. Vaibhavi Dasmana. I'm a third-year junior resident in the Department of General Surgery. Under the guidance of my HOD, Dr. Hemant Nautiyal sir, I'm going to be presenting a case of a 64-year-old gentleman who is a resident of Dehradun, retired from the army, Hindu, belonging to the lower middle socioeconomic class, who presented to the OPD with the chief complaints of upper abdominal pain for the past 1 year, on and off vomiting for the past 8 months, sensation of rolling mass in the abdomen for the past 6 months, and history of weight loss and loss of appetite over the past 6 months. The patient was apparently well 1 year ago when he developed an insidious onset upper abdominal pain, which was gradually progressive, mild to moderate in intensity, initially of a non-specific character with no radiation or referral of pain. Over the past 8 months, he developed complaints of progressive exacerbation of the pain after the intake of meals, and it is now of a colicky nature. The pain is now also exacerbated on intake of liquids. Previously, the patient's pain was episodic, and it was episodic and occasional in only after heavy meals. Now the patient is having pain every time he consumes a meal, and sometimes even if he takes large quantity of liquids. The pain became associated with episodes of on and off vomiting for the past 8 months, which were intermittent, non-projectile, bilious, non-blood stained, of a copious quantity, having a foul smell and occasionally containing food particles. The episodes of vomiting occurred approximately 1 to 2 hours after intake of the meal, and they were followed by a slight reduction in the pain. He also had complaints of feeling of a rolling mass in his upper abdomen for the past 6 months, which was again aggravated on intake of meals. The patient also had associated symptoms of on and off constipation and feeling of bloating after intake of meals for the past 6 months. He has also since then developed complaints of loss of appetite. Initially, the patient used to take 3 square meals a day, but now he is not even able to consume 1 full roti in a day. This was also associated with significant weight loss, which was initially noticed by loosening of clothes, and then the patient started documenting his own weight and reported a weight loss of approximately 10 to 15 kgs over the past 3 months. There was no history of fever, jaundice, black discoloration of stool, blood in stool, hematemesis, or history of corrosive intake. In the past history, he has no history of any similar complaints in the past, no history of pulmonary tuberculosis, COPD, asthma, type 2 diabetes mellitus, hypertension, or any other chronic illnesses. There is also no history of any surgical intervention in the past. Personal history. The patient is a reformed smoker. Initially, he used to smoke approximately 1 pack of BDs a day for the past for 15 years, approximately 15 pack years, and he stopped smoking 4 years ago. He is non-alcoholic with no history of any other substance abuse. He had history of decreased appetite associated with weight loss for the past year. He had history of chronic on and off constipation and history of increased frequency of micturition at night for the past 1 year. In family history, there is no history of pulmonary tuberculosis in the family and no known history of any malignancy. To summarize my case, a 64-year-old reformed smoker with no known comorbidities presented with the complaints of upper abdominal pain for the past 1 year, on and off vomiting for the past 8 months, associated with feeling of a rolling mass in the abdomen for the past 6 months, and history of anorexia and weight loss.
Is there any history of early satiety in this patient?
No, ma'am. He has not given history of early satiety. He simply states that after he just has a loss of appetite is what he is describing. He does not describe it as early satiety. He just does not have any desire to eat itself.
He's got loss of appetite itself. He's not able to, he's not feeling full after little intake of food. He's able to, how was it progressed for the past 8 months? He is able to tolerate solids or liquids like that? It decreased, or suddenly he had just like that loss of appetite?
Initially, ma'am, he was able to tolerate solids and but in smaller quantity. And now he is not able to tolerate even puree meals or even large quantities of liquids. If he takes, then he has feeling of abdominal discomfort, pain, and episode of vomiting.
Is there any history of distension of the abdomen?
As such, sir, he did not give any history of abdominal distension, but he had feeling of bloating or fullness.
Now you started with the comment that there is a proximal small bowel obstruction.
Yes, sir.
So how could you reach to such a specific diagnosis of a proximal small bowel obstruction?
Actually, the final diagnosis was based on the CCT and the
No, we are
intra.
not here discussing about the CT and all those, no? It is first the clinical all things, you know.
So clinically, the case is presenting as a gastric outlet obstruction.
But why it is not a gastric outlet obstruction? I again say that it is probably not gastric outlet obstruction.
Yeah,
So he has bilious vomiting bilious vomiting and no history of early satiety in this case.
That is what I'm asking. If you want to differentiate between stomach or it is small bowel, you have to look for all this. Whether it's the vomiting is bilious, early satiety is there. So easy fatigability is there because of the vomiting containing more of electrolytes. So all these questions you should ask to different, because you have the diagnosis early, you are going accordingly to that. You have to differentiate by history itself.
Yes,
No?
ma'am. He did not have early satiety, but the vomiting was bilious.
Yeah, Dr. Vaibhavi, that's what exactly we would like to tell you. When you started in the small bowel obstruction like that, your MS exam, they won't tell you, no? CT finding. Please learn. That's what I told for the other candidate. Interpretation, thinking. So there is one more important point here is that, you know, it's dominating with the severe colic abdominal pain and a foul smell, you know.
Yes, sir.
So what is this? What do you mean by that? Is it, do you think stasis of the food particles or undigested food particles? Like typically pyloric obstruction patient have a foul vomitus, but what do they complain? If there is a pyloric obstruction, total, let us say.
So the food particles come out even after a few hours after intake of meal.
And what he might have eaten previous day. So in your patient, what is it like? In your patient?
So he says it occasionally has food particles, but mostly it is greenish material comes out in his vomitus. But it has
greenish with the foul means what is
foul
it?
smell.
I'm asking you one important word to come here. What is feculent vomit? What is feculent?
So feculent.
Yes.
So feculent is vomitus having a liquidy consistency, mostly digested particles, and it has a characteristic feculent odor associated with it.
So what is it classical of? It's real classical.
Large bowel obstruction.
No. It is not large bowel obstruction. It is a intestinal obstruction. You are careful. Terminal ileum. Terminal ileum is the one where you get usually these issues. That does not mean it cannot occur proximally, but usually, typically. So this is what is important. So we are trying to see, since you have already started with the small intestinal mass, you know, it is okay. All right. There are a few things. Thank you.
Vaibhav, can you tell that what are the causes of bilious vomiting in a patient with a duodenal obstruction?
Sir, periampullary carcinoma may present with bilious vomiting. So periampullary carcinomas, which would be carcinoma of the ampulla itself and carcinoma of the duodenum. Sir, there could be stricture, tuberculous stricture that may cause bilious vomiting in
When you get the bilious vomiting and when you do not get the bilious vomiting in a duodenal obstruction.
Sir, if it is if the obstruction lies beyond the second part of the duodenum, that is involving the third part, beyond the second part of the duodenum, that is when we will have a bilious vomiting. Whereas if the obstruction is in the first part or in the second part before the opening of the ampulla, then the patient's vomitus will be non-bilious in nature.
So what are the causes of infraampullary obstruction of the duodenum?
Sir, SMA
Yes.
SMA syndrome.
Yes, SMA syndrome is one. Yes.
Any
other mass?
Pseudocyst pancreas, carcinoma head of pancreas, and carcinoma of the duodenum.
Have you ever heard of GIST?
Yes, ma'am. GIST can also present.
Can present.
Tuberculosis?
Tuberculosis?
Yes, so tuberculosis as well.
So what are the various types of duodenal tuberculosis?
Sir, tuberculosis in the abdomen, and generally it can be either intraluminal, in which case the tuberculosis is within the intestine itself, and it causes obstruction.
In the lumen, you never get the tuberculosis, is it? Do you get in the lumen the tuberculosis?
So it is mostly in the wall and then causing mass
The wall,
effect.
no? It is in the wall. No?
And then, sir,
whenever you talk of any obstruction, you
yes, sir.
Tell the causes according to lumen.
Yes, sir.
The wall and extra wall.
Extra lumen.
So what can be there in the wall and what can be there outside the wall because of tuberculosis?
Sir, there can be hyperplastic features which will cause the stiffening of the wall. It can be, sir, ulcerative, which will be also involving the inner wall. And then there can be a stricture following chronic inflammation.
Outside the wall?
Tubercular lymphadenitis can cause a mass effect leading to compression, and which will then present with obstructive features.
Yeah, so tubercular can be extramural or it can be intramural. Both can cause the duodenal obstruction. Right? Can you get a carcinoma of the duodenum?
Yes, sir. Carcinoma of the small bowel, however, although they are rare, carcinoma of the duodenum can also be present. Most commonly, it is adenocarcinoma that can present.
Good. Yeah, I think we can go to the examination now.
Examination, yeah.
Examination, general examination. The patient was examined. Patient was sitting, say, lying down on the bed, and he was conscious, oriented to time, place, and person. The patient was severely malnourished, appeared pale, and he was lethargic. Signs of muscular wasting were present in all four limbs. The patient had pallor, but there was no icterus, cyanosis, clubbing, lymphadenopathy, pedal edema, and he had poor oral hygiene with discoloration of the teeth, but there was as such no halitosis or foul breath on examination. He was afebrile. The pulse was recorded at 110 beats per minute, which was recorded in the right radial artery. The blood pressure was 90 by 60 millimeters of mercury in the right upper limb. And the SpO2, he maintained an SpO2 of 96% at room air with a respiratory rate of 14 breaths per minute. Coming to the systemic examination, the abdominal examination. On inspection, there was visible gastric peristalsis, and the stomach also appeared to be distended, but there was no gross distension of the abdomen. Instead, there was the stomach appeared distended as a separate mass. The overlying skin was normal with no dilated veins. The umbilicus was central and inverted, and all quadrants moved equally with respiration. There was no visible swelling at any hernial site, and the external genitalia of the patient was also normal. This is a video of the patient, where we can see that there is an upper a lump in the upper abdomen, mostly on the left side. On palpation, the stomach was distended and palpable. It had a soft consistency, and there was no irregularity of the margins or any separate palpable mass. There was no tenderness and no palpable organomegaly. On percussion, the liver span of the patient was normal, and there was no evidence of any free fluid. On auscultation, a succussion splash was present, and the stomach was on osculopercussion. The stomach was extending from the left hypochondrium to 2 centimeters inferolaterally to the umbilicus, and the bowel sounds were exaggerated over the stomach. On rectal examination, there was a skin tag present at 6 o'clock with an underlying healed mark of a fissure seen. There was no protruding mass, no discharging sinus or fistula. The perianal skin also appeared to be normal. On a digital rectal examination, the anal tone was normal. There was no ballooning and no palpable mass. However, the patient did have prostatomegaly, and the gloved finger on retraction was stained with stool. The proctoscopy was also suggestive of normal findings. On the examination of the rest of the systems, on respiratory examination, the bilateral air entry was equal, but there were fine basal crepitations present bilaterally. In the CVS examination, S1, S2 was heard normally, and there were no added heart sounds. In the CNS examination, the patient had intact higher motor functions, 5x5 power in all limbs across all joints. There was no loss of tone, no sensory neural deficit, and on eliciting the reflexes were also normal in this patient. After that is the management. Summarizing the history along with the examination, 68-year-old male with complaints of with no known comorbidities, reformed smoker with complaints of pain upper abdomen for the past 1 year, intermittent episodes of vomiting for 8 months, feeling of a rolling mass in the abdomen associated with anorexia and weight loss for the past 6 months, who on examination had a distended stomach, distended stomach with presence of a succussion splash.
So what is your conclusion from this?
Based on the history and examination, I would like to diagnose this as a case of gastric outlet obstruction beyond or proximal small bowel obstruction. That beyond D2 basically is what I'm saying, based on the history of the vomiting.
Will you call that as gastric outlet obstruction?
No, ma'am. Proximal small bowel obstruction is what I would prefer to say in this case.
In which other pathology you can get a succussion splash?
So succussion splash is classically heard in can be heard in carcinoma stomach. And so gastric
outlet obstruction is there. It is because of gastric outlet obstruction.
Yes, sir.
Any other pathology which is there where you can get the succussion splash? Not in the abdomen.
Sir, I'm
the chest.
Then I'm not able to think so involving.
Fluid is there and air is there in the chest. What is that condition called as?
So hydropneumothorax would be.
You get a succussion splash in hydropneumothorax also. Yeah. Okay, what is the normal lever span? You have written lever span is normal. What is that?
Sir, the liver span in this patient extended from the in the mid-clavicular line. The vertical extent was from the fifth intercostal space to approximately 2 to 3 finger breadths below the costal margin. And in adult males, it is 13 to 16 centimeters.
You can
3
never
finger
write
breadths
down.
below the costal margin, is it?
Okay, you have to always give the
Uh,
measurement for that. Na? Whenever you are telling about the lever span, you have to tell about that how much it is 13 centimeter or it is 12 centimeter or 14 centimeter in the mid-clavicular line.
Yes, sir.
So how do you find the upper border of the lever dullness?
On percussion, sir, there is on percussion over the chest. There is normally the note that is heard is resonant because of the air filling the lungs. When we hear the dullness, that is where the upper border of the liver will be present.
But how will you find that?
So on
How will
percussion,
you do that? How will you do that test to
so
find the upper border of the lever dullness?
the patient is asked to lie down, and we do the percussion in the mid clavicular line from up to down.
From where you will do that percussion?
So it's from the second intercostal space.
So
We
how
will
will you
come down.
how will you find the second intercostal space?
So we will on palpation at the so at the angle of Lewis, the space that is corresponding on palpation, we can feel the rib and the space underlying it. That is
So what is attached at the angle of the Lewis? What structure is attached?
The second rib is attached, so at the angle of Lewis.
Second, what second is attached? Is
So
it is the rib there or something else is there?
so the rib is attached there, and
No, it is not the rib there, no, which is attached to the angle of the Lewis. It is the
so
costal cartilage.
Yes, sir.
Costal cartilage is there.
Yes, sir.
And then when you move laterally to the mid-clavicular line, there you get the second rib.
That's where the rib starts.
So where is the second intercostal space?
So it
Above
is
or below?
so the space below.
Yes, space
the
below
second.
that, you know? Yes. And by that you find out the upper border of the lever dullness.
Yes, sir.
Okay. Now you can go to your diagnosis. You have made a slide of the diagnosis.
So the patient has actually undergone management. I have the final diagnosis, but I can tell you the differential diagnosis that I have considered in this patient.
So tell the differential diagnosis.
So based
Sir,
on
I have one question.
Yeah.
Vaibhavi, why did you ask for intake of corrosive in your history?
So I was trying to rule out other causes of stricture, sir. That is why I asked.
Will
Because
this patient of yours present with esophageal strictures this way?
corrosive intake can present with as an esophageal stricture as well, and in that case, the patient will have a history of dysphagia and
So your
regurgitation.
patient never had history of dysphagia.
Yes.
So you are trying to tell me through your history that this patient has isolated distal gastric outlet obstruction
Yes, sir.
because of corrosive intake?
No, sir.
No, thank you. So you have to correct yourself. Okay. Second, what is a reformed smoker?
Sir, a smoker who has stopped smoking for a period for a continuous period of 24 months or 2 years. That is a reformed smoker.
Is that the definition? He should be smoker before, right?
Yes, sir. And a person who has quit smoking for a period of 24.
How much should he have smoked before quitting?
Sir, at least 100 BDs or 100 cigarettes.
Okay. The third question of mine is visible peristalsis.
Yes, sir.
you have examined this patient, you've got visible peristalsis.
Okay.
Can you describe visible peristalsis to me?
So visible peristalsis is basically a wave-like motion that we can see usually in lean and thin patients that occurs in the direction that is opposite to initially it will occur. So the direction of the peristalsis is from right side to the left. So
How
left to
will
right.
they differ between a pyloric obstruction and a duodenal obstruction?
So in pyloric obstruction, we will have movement of the visible peristalsis from the left side to the right side. And in duodenal, there is a step ladder pattern of the
Very
visible
nice. Very nice. You said patient has prostatomegaly. Why?
Yes, sir. Sir, on examination, on the digital rectal examination, sir, I could feel a firm mass, but I could also feel the median sulcus and approximately two
If
finger.
you find a median sulcus,
Okay.
what are the criteria that you have to call it prostatomegaly?
So
Because patient has no symptoms.
So he has increased frequency of micturition at night
Okay.
for the past 1 year. Aside from that, he does not have any hesitancy or any other complaints, but he did have increased frequency of micturition at night.
So with
But
frequency of micturition and your examination, how did you come to a conclusion that this patient has prostatomegaly, which is responsible for his symptom?
So he had, there was a median sulcus was palpable along with bulging. I could feel the bulging of the lobes, approximately 2 finger breadths on either side of the median sulcus.
Can you just, if at all you do a PR examination in a normal patient who has no symptoms,
yes, sir.
What would it be your findings on per rectal examination?
So we will find a firm mass can be felt in that case. At the anterior aspect.
Is upper border of the prostate important for you? Read about it. I will not answer anything here. The second question I want to know is, you talked about cardiovascular examination. Where
Yes,
is the S1 and S2 heard?
Sir, so the S1 short sound is heard in S1
That's the problem.
S1 is mitral area. So S1
Where is apex beat heard?
So the apex beat is heard in the on the
Possibly
right.
no word of possibility here.
So left side in the fifth intercostal space is where in the mid clavicle. So
Okay,
medial to the mid clavicle.
Fine, I've understood. Other examiners can take over. Thank you very much.
Dr. Vaibhavi, just a few questions only, because we are talking about now probably distal to the stomach causes. Distal to the stomach. Can you quickly tell me length of the D1, D2, D3, D4, and quickly tell me few causes for this obstruction when the mass is not palpable? See, your patient has got a no mass palpable. Don't describe that wave of peristalsis as a mass. I have seen that you said soft intensity. That's a common mistake. Wave is a temporary wave. Wave comes and goes. When the wave is coming, you keep your hand, you can feel that contractions, like in interception. Now here, there's no mass palpable, so it's only stomach which you felt as soft. Quickly, you tell me now D1, D2, D3, D4. Quick.
So the length or?
Yeah, length and causes. D1, next D2, next D3, and D4. That's all. Think. Simple.
So D1 has a length of approximately 5 centimeters. D2 is approximately 7.5 centimeters. D3 is
3, yeah, very good. 2, 3, 4, 1. This is a way to remember inches. Okay. 2 inches, 3 inches, 4 inches, 1 inch. Now you start thinking from D1 level, D2 level, D3 and D4. If at all, what may be the cause for obstruction?
Okay, sir. So at D1, obstruction may be due to chronic duodenal ulcer followed by stricture formation.
Post-bulbar, what you are talking, post-bulbar ulcers and all, generally they produce with the, actually, first part only the obstruction, actually speaking, even though called as pyloric obstruction. That's why gastric outlet name came. Go ahead, next. Yes, go ahead.
So also, if there is a carcinoma of the pylorus of the stomach that is infiltrating, that can also cause obstruction at
Just hold on. You know, for whatever, it doesn't infiltrate duodenum that easily, you know. Most of the time, whatever be the advance, it happens over the lesser curvature and gastric. That's why duodenal side, you don't require very wide margins. You probably, you know, careful. Yes, next. Go ahead. Any other causes? D2, D3, D4.
So at the level of D2, the obstruction may be a mechanical obstruction due to carcinoma head of pancreas, due to a pancreatic pseudocyst. It may be also due to periampullary carcinoma.
Periampullary carcinoma, duodenal carcinoma, head of the pancreas, all that is true. Mass may or may not be palpable. If there's no mass, also in adults, think of adults. Annular pancreas, not in your patient. I'm just trying to give you. And of course, in children, they are different category where bed set. Now, third part. Yes.
Yeah.
Third part.
So third part of duodenum, SMA syndrome.
Excellent. Anything else?
Against the pancreatic pseudocyst can
If the pancreas related, remember to have a carcinoma pancreas itself. You know, it's very close there. And remember, tuberculosis always has some lymph nodes, sometimes can give rise to third part. Even the fourth part is a very small segment. Why I asked all these questions is, when the mass is not palpable in the abdomen, patient has no jaundice. Patient has no jaundice to think of head of the pancreas, periampullary carcinoma, etc. All these things will come into the picture. Whether you talk about the body of the pancreas or talk about the lymph nodal mass, because there's no mass palpable in your patient. Okay, so you think in that direction, and then you have to clearly mention, when you are mentioning your palpation finding, no other mass palpable, clearly. Because you show me that your slide of that wave with the peristalsis, just only 1 minute I will take. Yeah, no, not this. Yeah, this I have seen. This I have seen. The next. Yeah. See, you have only written there no tenderness and no palpable organomegaly. Please do not make such vague statements. See, you have to look for masses here. If you are suspecting terminal ileum or ileocecal tuberculosis, you have to specifically look for the masses in that area. Okay, so that is important. You are, instead of trying to make a vague statement. Okay, and also percussion, you have written there liver span normal. So again, percussion, you should have probably clarified here that stomach, whatever you felt, stomach means whatever, that distended stomach. You have written there succussion splash present, but again, the distended stomach, you may have to write also how much is the greater curvature distended. Okay, and what is this bowel sounds exaggerated over the stomach means what? Nobody will do that.
So
we don't do that. What is that? What is that you have in mind? Bowel sounds means what is that you are hearing normally?
So the peristaltic movements.
Of what?
So
stomach, colon, small intestine.
So of the flexure of the colon. Yeah.
Normally, we auscultate. That's why, see, when you write, you should know somewhere in the right iliac fossa there, because where is the ending of the small intestine? Where does the ileum, small intestine end? Where does it end?
The terminal ileum and the colon join to form the IC junction, which is on the right lower quadrant.
So that's in fact called as abdominal post by Hamilton Bailey. Hamilton Bailey's clinical science, it is as abdominal post. So you have to auscultate there for the exaggerated bowel sounds in an obstruction case, or mid umbilicus if it's a higher obstruction. So classical ileal obstruction, that's correct. Otherwise, high jejunal above for any noisy sounds. So don't say exaggerated over the stomach. Okay. You would have auscultated in the umbilical region or right larynx. Yeah, that's all, sir. Thank you.
The patient was admitted and an Ryle's tube was inserted, and there was a 2.5 liters of bilious output within the first 30 minutes. And the gastric distension and feeling of bloating was relieved. He was resuscitated using IV fluids and he was put on analgesics. The patient was evaluated using a CCT. At the time of presentation, he had a CCT which had been done 6 months prior, which had been done elsewhere, and it showed a mild mucosal enhancement and thickening and edema involving the gastric mucosal wall, likely inflammatory. After admission, the patient underwent an upper GI endoscopy, which was suggestive of grade C esophagitis, along with the distended stomach and duodenum. And the gastroenterologist had doubts of an obstruction distal to the duodenum. A CCT of the abdomen was also repeated here, which showed dilatation of the proximal jejunum and duodenum with overdistension of the stomach, and a transition point which was noted in the proximal jejunum lying in the pelvic cavity with focal circumferential wall thickening, which measured approximately 14 by 18 millimeters, which caused stenosis and collapsing of the bowel loops distal to it. The luminal diameter of the jejunum was 4.5 centimeters. The duodenojejunal region was also collapsed by the distended stomach. And in the peritoneal cavity, there were some areas of the free air density. Okay. And the findings were suggestive of grossly distended stomach, duodenum, and proximal jejunum, along with short segment circumferential stenotic wall thickening. This is the video of the CT film, the CT that was conducted. We can see the cross dilatation of the stomach as well as the bowel loops. The patient was then taken for surgery, and he underwent an exploratory laparotomy. In the intra-op findings, there was an hourglass stricture approximately 1 foot distal to the duodenojejunal junction, and the distal bowel was completely collapsed, whereas the proximal bowel was found to be dilated. This is the small stricture that was observed. And the stomach, as mentioned in the CT, the stomach was also found to be grossly distended. There was a resection of the strictured segment along with the side-to-side jejunal anastomosis. The sample was sent for histopathological examination, and on histopathological examination, the jejunal bowel loop with the stricture showed a moderately differentiated adenocarcinoma, which was infiltrating the subserosal sac. The resected margins, however, were free, and one out of the 3 lymph nodes showed a tumor deposit. The patient was ultimately diagnosed as a case of adenocarcinoma of the small bowel, specifically the jejunum.
What are the other common tumors which can arise in the small bowel, especially the jejunum?
Ma'am, tumors arising in the small bowel can be adenocarcinomas. There can be lymphoma. It can be gastrointestinal stromal tumor or GIST. And there can also be carcinoid tumors.
Carcinoid is also good.
Where did you do a plain X-ray of the abdomen in your patient?
So the plain X-ray of the patient was done, but as the patient has already been discharged, I was not able to attain the films for this session. Sorry for that.
Well, what are the findings will be there in a patient with intestinal obstruction?
So there will be a step ladder. There will be multiple air fluid levels which will be seen. Along with, we can also see distended bowel loops based on the level of the obstruction.
Normally on the plain X-ray abdomen, how many bowel the bowel levels you see? How
Uh,
many fluid levels you see normally?
Normally, so we see 3 air fluid, 2 to 3
Um,
air fluid levels can be
What
seen.
are those sites? Where do you get that?
So the first is at the fundus of the stomach,
Yeah.
where we will see an air fluid level. The second is at what's the stomach? Let me check it. Uh, so air the first is at the fundus of the stomach. Then we can see and the one in the small bowel and is in the large bowel.
No. Second one is near the duodenojejunal one, and third is near the ileocecal. When do you say it's a dilated bowel loop?
So it is based on the which part of the bowel loop is
Small bowel.
dilated.
Yeah. Tell about the small bowel.
For the small bowel, if we see if it is approximately 5 to 6 centimeters, we can see that it is appears to be dilated. Whereas in the large bowel, 8 to 9
6
centimeters.
centimeters is too much, no? If it is more than 3 centimeters is there,
3
then
centimeters is small
it is
bowel.
a dilated bowel loop. How do you differentiate that it is a jejunal loop or a ileal loop or a colonic loop?
Okay, sir. So colonic loops will be first present in the peripheral area of the stomach, and we can see the presence of hostra or the hostrations that will be seen in the large bowel.
How do you define the hostra on the X-ray? How do you say it is a hostra? I say it is the small bowel.
So there is incomplete separation.
Incomplete, yes, and at different levels.
Yes.
And in the jejunum and the ileum, what will happen?
So in the jejunum, we will have volvic comitants, which first,
Conjuventis, no? Volvuli conjuventis.
Conjuventus.
and
Yes.
that is complete in there directly in
Yes.
in front of each other, parallel basically to each on each side. And
What is that effect called as? What is that?
corrugated pipe. No, not
Concertina effect. You know what is
Concertina.
concertina effect?
So it's an instrument.
Yes, the instrument is there, yes.
According.
And the ileal loop, how does that look like?
So the ileal loop is featureless. So ileal loops
Featureless.
are characteristics of featureless.
Right.
Yes, sir.
So in your patient, what was the finding? What did you get in your patient on the plain X-ray?
So there were multiple air fluid levels, and there was distension of the jejunal.
No, but if you see multiple air fluid levels, then you cannot say it is a upper small bowel obstruction.
Yes, sir.
Okay. If you say multiple air fluid levels, then it's a ileal obstruction or the lower jejunal obstruction is there.
In this patient, there was dilatation of the jejunal loops. Is what?
Just say only in the upper part there was a dilated loop was there. Then you can say it is a upper small bowel obstruction is there with dilated duodenum and the stomach.
Yes, sir.
That can also be seen in the plain X-ray abdomen. There is a dilated stomach and the duodenum is there. Okay. So what are you going to do for this patient? You have done the resection. Margins are free.
Yes, sir. So based on the histopathological report, the resected margins were free from the tumor. So the management of malignant small bowel malignant lesions is based on the size of the lesion as well as
the margin of resection in the case of small bowel tumor.
So it is at least 10 centimeters, five proximal, 5 distal, at least 5 centimeters.
Either side, 5 centimeter. At least it should be there. So did you achieve that 5 centimeter here?
Yes, sir. So in the I've not included the gross examination in this report, but there was around 6.2, 6.1 centimeter proximal, and it was around, I think, 6 centimeter also distal of the structure was resected totally.
So what is the plan now after this resection?
Sir, after the resection, so there is in any case of GI malignancy, there is a high 5-year recurrence rate is high, especially in adenocarcinoma of jejunum. There is a 30% recurrence rate, even if there is clear resection. So I would like to have the patient on chemotherapy with 5 fluorouracil and capecitabine, and we can also do.
What is this chemotherapy called as when you are giving in this patient? What is that chemotherapy? You said the neoadjuvant. Is it the neoadjuvant here?
Oh, so that is before the, I misspoke.
In this case, what it is? If you are giving the chemotherapy, what is this chemotherapy?
So
no, I'm not talking about
Adjuvant.
adjuvant chemotherapy.
Adjuvant. That's all. See, you said 1 out of 3 nodes are positive in this patient. So
Yes.
how will you follow up this patient?
The follow-up of the patient should be with first the patient should have a consultation with radiation oncology. So patient should be started on chemotherapy, and there can routine follow-up of the patient. So we can do a PET CT in this case first to see if there are any other active nodes or any metastasis, and then follow up once every 1 year, once a year.
What are the complications you expect from this patient?
Ma'am, there can be ma'am, the operative complications or the complications of the adenocarcinoma?
Operative, post-operative?
Okay. So, ma'am, in the operative complications, we can have the early complications or the late complications in this patient. And early complication can be hemorrhage. There can be anastomotic leak. There can be post-operative ileus. There can also be
Most common is stricture from you went for side-to-side anastomosis, no, in this patient? Not end-to-end.
It would be a late complication. It wouldn't be an early complication. So in late complications, the most common would be a stricture formation.
So we went for side-to-side anastomosis in this patient, no?
Yes.
Vaibhavi, 1 or 2 questions from my side.
Yes,
1 or 2 questions. If this patient were to come with some kind of a subacute obstruction,
yes,
where you take an X-ray, you find that kind of a whatever dilatation of the proximal jejunum. Any other investigation you can do? I said subacute, the word patient is stable, where you can get a histological diagnosis.
Sir, we can do an endoscopic. We can do an endoscopy and biopsy.
Wait. Where? What endoscopy?
Sir, double balloon endoscopy.
So what is it called as? Yes, correct. Yes, correct. What you told is right. It's a push endoscopy, endoscopy,
or a double balloon.
Where you can take a histologically biopsy. Number 1, first question. Second question. So any other investigation in us, because we are asking because this is basically a small bowel obstruction, like since it's a jejunum. Adenocarcinoma is rare. Since you got the case is different. Your case, any other causes for stricture in that area?
Sir, tubercular stricture.
Definitely yes. What else? Any other? So ischemic strictures. Don't forget ischemic strictures. Recurrent some kind of ischemia. Ischemia is one of the worst enemies for a stricture. It should get a more frequency. So tubercular strictures, ischemic stricture, iatrogenic, some inflammatory strictures, apart from those neoplasm, whatever you mentioned. big list, whatever carcinoid, whatever you can call it, neuroendocrine tumors, and all this lymphoma. Never forget lymphoma, because this is the one which area where you can get those lymphomas. So that is one thing you should keep it in mind. Okay, that's all from my side. Thank you.
Ravi, what are the various ways to investigate the small bowel?
Yes.
One,
Sir,
you told about the push enteroscopy.
Yes, correct.
What are
so,
other ways to investigate for the small bowel?
there is the video endoscopy as well, in which case a small video capsule is ingested by the patient, and
Is that called as
so capsule endoscopy.
capsule endoscopy?
Yes, sir.
You
So
know how many pictures they come in the capsule endoscopy?
sir, it takes 2 images per second.
Hmm?
Sir,
In total, how many images they come?
so I don't know in total. I just know per second it is given that there are
It's
two.
around 50,000. 50,000 pics they come in the capsule endoscopy. You know? And that is why a man cannot read that. And there's a big place for what is called the artificial intelligence, which is coming for reading all those so many pics which are there. Okay, so that is one is capsule endoscopy. Any
Yes,
other
sir.
thing by which you can investigate the small bowel?
So there's a that's what I. So mini colonoscopy.
You know,
The very terminal small bowel can be seen.
you can do the terminal ileoscopy. No? You can do the terminal ileoscopy. Okay, when you're doing the colonoscopy.
Yes, sir.
That is for the terminal ileum. Any other barium studies or CT studies, you know?
CCT of the
What is that called as CACT if it is there?
so we can do a triple phase CT can be done, and so then there is the barium meal and barium meal follow through.
Triple phase it is. Triple phase is for like the pancreas and all those, you know? But here what you do, what is the name of that CT?
So contrast enhanced CT, CCT.
It has to be contrast for all those things.
Um,
You are investigating the small bowel, so you call it as a CT.
CT enteroscopy. Enterography. Yeah.
Enterography. You know, it is called as CT enterography. When you do the barium studies, what is that called as?
The barium meal and barium meal follow through. So
again, there's a name for that.
so that I'm not able to recall.
Enteroclysis. Okay,
Yes, sir.
it's called a small bowel enteroclysis.
Yes, sir.
Okay, so these are the various ways you can investigate the small bowel lesion. Okay.
Vaibhavi, I have one question for you.
Yes, sir.
You have opened up this patient. What are the things that you will suspect that this is something different?
So
See, common strictures are tuberculosis, etc.
Yes, sir.
When will you suspect that this is something different?
So the hard consistency of the structure, if it is hard.
Very good.
Associated with the surrounding mucosa, if it is also indurated.
Mucosa will not open, no? You have opened this patient for obstruction.
Yes, sir. So we can see there might be omental deposits, which we can find.
No. Now you're going to theory. I am not going to theory at all. You have investigated this patient completely with CT, etc., etc. You opened up this patient for obstruction.
Yes, sir.
Now you find a jejunal stricture which is very rare. Now you get into a problem whether to do a formal resection for malignancy or do a limited resection. So how do you decide that?
Hard consistency. There was the
One.
The folds of the stricture, if they are converging or diverging.
Fold you are not going to see anyway.
Yes, sir.
The second thing you see is the node, right?
Nodes. Yeah.
Yeah. So you've got one of the three nodes which are positive. So what are the options in front of you, whether you should do a proper resection or do limited resection? It's absolutely a practical question I'm asking you.
Yes, sir. So I think based on the finding of the stricture and the lymph node, I think a proper resection itself should have been done in this patient, especially given the fact of his age and the age, the history, and the no history of any tuberculosis or tubercular contact. I think it is better to assume that the patient might have malignancy, even if it is a slim chance. And
Yeah, but will you ever suspect malignancy in the jejunum? That's the issue.
No, sir, it is very less common. The small bowel itself is only around 1 to 2%.
Don't talk theory with me.
Yes, sir.
I'm asking you a very practical question. Hard mass, you suspect malignancy.
Yes, sir.
That is the time a surgeon decides whether to go ahead with a massive resection or no resection, limited resection. What are the options in front of you in case you are in a good medical institute to determine whether to do
We can do
proper
the
resection?
fresh frozen margins can
Very
be
good.
taken.
What did you answer?
So the frozen section of the resected margin can be taken.
Margin you want to see, or you want to see
nodes.
On excision of the stricture itself, the stricture can be first examined, and then after
Exactly.
that you can
Why do you want to wait?
Yes, sir.
Just resect and wait for. I agree with your answer about resection margins, but ask the pathologist to tell you whether there is malignancy or no.
Yes, sir.
Now, since it is, where was the lesion exactly in the jejunum?
So it was approximately 1 foot from 1 foot distal to the duodenojejunal.
Very good. Very good. Can you tell me the blood supply of the first part of the jejunum?
So the first part of the jejunum is supplied by the superior mesenteric.
Correct. What is so different about first 6 or 8 inches of the jejunum that it receives from the superior mesenteric artery and then supplies the rest of the intestine?
So this
it's a very dangerous place.
Um,
10 मिनट बात करो, अभी क्लास में है ना, 10 मिनट के बाद.
Wherever you got to read
yes, sir.
a little bit on the proximal jejunal blood supply. I think Dr. Khanna will agree with me. It's a completely different situation when superior mesenteric artery supplies the proximal jejunum immediately distal to the duodenal jejunal junction, as apart from the rest of the place. Okay?
Yes, I'll read. Sir.
Most of the times these are end arteries, and anastomosis becomes very difficult. But nice presentation. You have read well. I'm with you. Thank you.
How do you differentiate between a small bowel tubercular stricture and a Crohn's stricture at operation?
It's an intraoperative differentiation between a Crohn's stricture and tubercular stricture. Tuberculous is so tubercular strictures are more commonly so no wait. So just give me a minute.
What is the gross appearance of the crowns?
So the tubercular strictures are more commonly present transversely, whereas the Crohn's strictures are present along the longitudinal dimension. The tubercular strictures are also proliferative in nature, uh, but the involvement of the mesentery is not as common as but in Crohn's there is a fibrofatty proliferation and involvement of the mesentery as well. There is there is a lymphadenopathy that is associated with the tubercular structure, and as compared to those in Crohn's disease, the lymphadenopathy is less so. In tubercular, there is a marked lymphadenopathy. There is and the Crohn's will also have a cobblestone appearance within the lumen.
At operation we are talking, cobblestone you will not see from outside, For that you have to do enteroscopy and all those to see for the cobblestone. What is the length? The most important, the length of the stricture. Which is short stricture and which is long stricture.
So tubercular has a longer stricture. Crohn's will have multiple, but
the other way around.
Jayakana sir, you're muted, I think.
I'm not able to hear, sir. I'm sorry.
Yeah, you muted, I think, sir. Yeah.
Sorry, yeah. Again, I will tell you, tubercular strictures are short strictures,
yes, sir,
while Crohn's are the long stricture. And that is why you can very easily do a strictureplasty in the case of the tubercular strictures, but not in the Crohn's stricture. It can be done, but it is difficult in the case of the long strictures. Second is the overriding of the mesentery. If you find there is a fat mesentery which is there is overriding over the bowel, it is more in favor of a Crohn's stricture. Third, the lymph nodes are present in both cases, but in case of tuberculosis, it is the cageous type. While in the case of the Crohn's, it is the non-cageous. So this is the way at intraoperative that you can decide about whether it is the tuberculosis or whether it is the Crohn's. What are the various types of the intestinal tuberculosis?
So the intestinal tuberculosis can be either hyperplastic, it can be ulcerative, or it can be hyperplastic, ulcerative, and proliferative. So intestinal. It can be
mixed
either
variety, also hyperplastic variety.
hyperplastic.
So which one leads to stricture formation?
So the ulcerative type will lead to stricture formation.
So after healing of the tuberculosis,
healing by
giving the patient the ATT, it has healed, and then it will lead to a stricture formation. Which is primary and which is secondary? Primary, ulcerative or hyperplastic? Which one is primary, which one is secondary?
So the ulcerative type is so ulcerative type is primary, I think.
No, it's other way.
No, hyperplastic type is primary, ulcerative is secondary abdominal. Sorry. I'm so sorry.
Hyperplastic is primary.
Hyperplastic is primary.
Ulcerative is secondary. Virulence of the bacteria is much higher in the case of ulcerative variety as compared to the, and host defense is better in the case of the hyperplastic variety, while poor in the case of the ulcerative variety. So these are the various differences between the primary
and secondary,
hyperplastic, or secondary as the ulcerative variety. Okay, I think Dr. Kanagavel, can we stop now?
Maybe you have done very well. I think you answered most of the questions, and your presentation is also very good.
Thank you.
Is Dr. Kanagal there?
Well, I think he's not there.
Okay, well, we will stop at this place. If you want to ask any question, you're welcome to ask.
I don't think so, sir. I think everything was cleared up as we went along in this case.
Okay.
Most of the doubts.
Thank you.
Yeah,
Questions.
you did well. And I must compliment Dr. Kunnotiyal also for that, yeah, for preparing the story. Yeah. Okay.
Thank you,
Thank
sir.
you.
So actually,
Thank you.
she just entered into third year, so they're very fresh
Okay.
third years.
Okay.
So we are motivating them to present, so they learn from their mistakes.
Right.
So that is the purpose, I think, in presence of so much senior teachers.
Yes.
So thank you very much, sir, for your
Thank you.
contributions. And yeah, ma'am, thank you very much.
So Dr. Kanagal is there? No, he's not there. Yeah, Dr. Kanagal has come. Yeah. Dr.
Yes, sir,
Kanagal?
yes.
Yeah. Can we stop now?
I think he's not there, sir. We'll stop.
Thank you.
Thank you. Thanks.
He's there. Yeah. He's there. Yeah. I
He's
think
there,
he's
huh?
driving probably. Yeah.
Yeah.
I was in the with us, sir. I'm back now. I was a faculty here. I think we are fine with that. Faculty, you would like to ask fine with that?
Dr. Kanagal, your connection is not, because I think probably you are traveling, no?
Driving, yeah.
Yeah. Mm-hmm.
Thank you, Kanagavil.
Yeah.
Okay, thank you. Thanks,
Okay.
Chalo.
Good night to everyone.
Okay,
night.
good night. Good night, everybody. Good night.
Thank you very much. Good night.
Good night.
Thank you, sir.
Good night, madam. Thank you.